Hello, everybody. I'm going to give you a few moments while people join us, and then we will get started for our 3 o'clock webinar. If you are joining us today, we are here. If you're in the right place at the right time, you're here for our webinar series, Partnering with Legal Aid Providers um, to Improve Behavior and Mental Health, talking today about Certified Community Behavioral Health Clinic Medical Legal Partnerships, specifically to support adults. So thank you for joining us. We will get started in just a moment. We are coming together today. This is part one of a two-part series. The next part will focus on pediatric patients, and it'll be next month on February 26th, same time of day. But today we are focusing on adults. So with that said, I'm going to jump in and trust that if you are joining us, you will probably have heard some of these introductory comments before. So if you miss it, you can patch it together. I am one of today's moderators. I'm Katie Hathaway. I am a consultant for the National Center for Medical Legal Partnership. And in a few moments, you'll hear from Bethany Hamilton, who is the director of the National Center. She is today's other moderator. And we will introduce the speakers in just a moment. We have a wonderful slate of folks who are joining us, a team from New Jersey, joining us to talk about this really important topic. Just a quick overview and reminder, this project is supported by a grant from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. To the National Center for Medical Legal Partnerships. So the content that we present today here is not endorsed by or represent the views of the federal government, but is the content of the speakers and the National Center. Couple of housekeeping things real quickly. If you've done a Zoom webinar before, you're probably very familiar with this. Please mute yourself during the webinar so that we can reduce background noise. If you have questions or comments or things that you want to share with others in the webinar, please use the chat box to do that, or the question and answer pane there to send us questions, to add anything. You can select live transcript and show subtitle to activate captions. And then a reminder, as most webinars you're probably familiar with these days, we are recording this so that we can share it afterwards and post it on our website. You will also have access to the slides and to the audio recording. So we have a few learning objectives today. The first one here is we're going to learn about updated data concerning social risk factors that contribute to behavioral health issues. We want to improve our understanding of how the unmet social and legal needs can impact behavioral and mental health access and the outcomes for low-income and diverse adult patient populations. And then, of course, learning about the role of medical legal partnerships as an intervention in behavioral and mental health care. And I think you'll really appreciate hearing from a program in New Jersey that is working on this very successfully. So let me introduce you to our speakers today. We have a panel of 5 folks, as you can see here. I'm going to give you just a brief introduction to each of them, and you'll get to appreciate their expertise when you hear from them in a moment. But they each have long biographies that we don't have time to read every part of today. But let me introduce you to the team from the Community Health Law Project and Care Plus New Jersey. Starting on the left-hand side of the screen here, we have Erica Kerber is the president and executive director at the Community Health Law Project, where she's been for over 20 years, starting as a supervising attorney and including roles as a managing attorney, the director of litigation, and an associate executive director. Erica sits on the board of the New Jersey Association of Mental Health and Addiction Agencies, as well as the New Jersey Mental Health Institute, in addition to many other leadership and advisory roles in the community. Sean Benoit is the Director of Litigation for the Community Health Law Project, where he has been on staff since 2019, first as a staff attorney and then managing attorney before becoming the Director of Litigation. And prior to his time at the Community Health Law Project, Sean spent many years as a legal advocate for individuals with disabilities, focusing on helping children and families with special education legal issues. Rehanna Rasul is the managing attorney for the Bloomfield office of the Community Health Law Project, where she has been since 2016. She oversees the office's various programs, litigation, and outreach activities, as well as supervising a team of attorneys and advocates who work to make sure disabled clients receive both holistic and empowering legal help so that they can live independently in their communities. And then moving over to the team from Care Plus, we have Bridget Johnson is the president and CEO of Care Plus New Jersey, where she leads the delivery of integrated mental health, addiction, and primary care services to over 14,000 individuals annually across northern New Jersey. She's dedicated over 25 years to advancing access to equitable care and is a national advocate for behavioral health equity and sustainability, working with stakeholders to expand the certified community behavioral health clinic model and improve access to comprehensive care. Bridget serves on the board of directors for the National Council for Mental Wellbeing and with Erica on the New Jersey Association of Mental Health and Addiction Agencies. And finally, Sandy Newman is joining us as the Client Resource Manager and Client Advocate for Care Plus New Jersey. She has over 34 years of experience working with the severe and persistent mental illness population. And since 2018, her focus has been to help educate about the resources available to clients. Through the partnership with the Community Health Law Project, Sandy empowers clients to continue to work on their treatment goals and manage any legal matters that could hinder their success. So welcome. Thank you for joining us today to Erica, Sean, Rehanna, Bridget, and Sandy. So we're going to start with a poll. We'd love to know who you are, who's joining us today. I think some of this information was on our registration, but if you could let us know who you are, what kind of organization you are joining us from today. We would love to know that. Looks like we have quite a lot of civil legal service organizations, a lot of lawyers out here, some health centers, some other community mental health centers. Wonderful. Okay. More responses. Okay. We'd also love to know about your organization. Does your organization have a medical legal partnership? So we can end this poll. Okay. Can we move to the second poll? Okay. I'm not sure what's going on with the polls, but let's fast forward if those are not working for us. Let's see.
Hi, Katie. Sorry to interrupt.
Yeah,
It looks like
that's okay.
all three poll questions were showing up at the same time. Able to unmute and want to and can still see the results to highlight that would be helpful.
Okay.
Otherwise, we can continue moving along.
Okay. Well, it's also something, if you have an opportunity while you're listening to us here today, share a little bit about whether you have a medical legal partnership. Does your work focus on mental or behavioral health needs? Feel free to put that in the chat box so that others can see and learn who you are. Okay, why is this? Bethany, is this you?
Yes.
Okay.
Thanks, everyone, and apologies. We are actually experiencing, for several of us, some problems with Zoom. Surprise, surprise. So, and then feel free to type in the chat any responses or questions that you may have, or let us know if we are having any audio or video problems. So thanks for bearing with us and thanks for joining us. I'm just very quickly going to cover, for level setting purposes, what is MLP to make sure everyone understands it, especially if you're new to the medical legal partnership space. Help you understand it as a patient-centered healthcare delivery model that helps us move upstream using an interdisciplinary collaborative approach to care. Let's go to the next slide. So on the next slide, you'll see the typical the standard definition that we utilize to help people understand what is the medical legal partnership or MLP approach. We define it as an intervention where legal and healthcare professionals collaborate or partner to actually assist or help patients resolve their social or economic or even environmental factors in the community that can contribute to worsened health outcomes or health disparities, and which actually have a remedy or solution in civil law. That's where the lawyers or the legal services professionals come in, is to provide that remedy utilizing their expertise. There are other approaches to connecting people to legal care, if you will, to address those health harming legal needs. But we don't define those as MLP. So what's not MLP is also listed on the screen, and it's not to diminish or discount the value of these things, but these aren't quite what we would call a full-fledged collaborative model. So a legal referral network where a patient is handed a list of providers in the community, and that patient is the one who has the onus is on them to then follow up with that provider. Perhaps the reason that provider is on the list is because you formed some sort of legal referral network, but you're not going to ever receive the information back necessarily because it's not systematically designed in your approach. You may not receive information back from your patient about whether or not they connected with that provider or that provider was able to assist them in some way and report on an outcome. Legal clinics are great, same thing, not necessarily an MLP, providing only legal information, not necessarily a medical legal partnership. Screenings, that's certainly a part of medical legal partnership and the approach, but only conducting screenings is not MLP. Partnering without equitably sharing the costs and benefits of a partnership is not MLP. And in partnerships, not actually engaging a lawyer for that legal expertise is not considered MLP. All right, so on the next slide, what do MLPs actually get done? You'll absolutely get to hear more about this from the team that's presenting today, but here is how we describe it in buckets, if you will, of activities. First, yes, MLPs are in fact providing some direct legal assistance to patients to actually help them address those health harming legal needs. But MLPs, because they are collaborative, right, they're also engaging in trainings that help the workforce, so the healthcare providers better understand what is a potential legal need, and then how do I provide a strong referral, and then how do I follow up with the patient or the legal services provider to better understand what the outcome was of that intervention. MLP staff are also working together collaboratively to engage in clinical level changes. And then they also work on those more systemic changes, such as working on policy issues or strategies to ensure that entire communities or population health outcomes can be achieved through their collaborative work. MLP really is about helping legal aid move with healthcare upstream to transform this healthcare ecosystem that we're all in together to create a more inclusive and impactful system of providers. On the next slide, you'll see some of the core components of the traditional medical legal partnership model. So you have a lawyer who's actually on site in residence in the healthcare setting. A formal agreement will be in place, such as a memorandum of agreement or understanding, really laying out the terms of your partnership. Some medical legal partnerships decide we have a high-risk population in our community, such as veterans, and that's a population that we're going to focus on together for addressing their health harming legal needs. Other elements of the traditional MLP model include screening for legal needs, I had mentioned, dedicated legal staff, including an attorney, conducting those training activities on those social drivers or non-medical drivers of health that are legal in nature, sharing information between partners so that you can actually close the loop and know what was the outcome of your intervention, and then the equitable sharing of resources to ensure that legal teams and healthcare teams are not just collaborating, and the burden of that actual expense is lying only in one house, but it is shared equitably. That's true collaboration. The distinction between the traditional model and a newer growing type of model is the academic MLP. So in this last slide that I'll present, I just want to display the distinctions that you'll see with the academic MLP. So on the bottom, you'll see the lighter blue slides that our friends at the Georgetown Health Justice Alliance team helped to identify. And these really help to identified the unique approach that academic MLPs take. So they prioritize educational goals for pre-professionals, where the academic component comes through School of Medicine or School of Law. And they are intentionally curating those learning environments because, again, it's an academic setting to ensure that you have interprofessional learning and education that's carried out. And they, because they're academic in nature, again, they have this commitment to really advancing the evidence base. So they're collecting data, research, and evidence, and then publishing that, right, to help fuel the further growth of medical legal partnerships overall. That's it. That's a level setting approach. Let's turn it over to the New Jersey team to really talk about what this looks like on the ground in action and when applied to the behavioral and mental health field for adults. Thank you.
I think that's me, right?
To you, Erica.
Thank you, Katie and Bethany. Thanks for having us. We're excited to share the work that we do with all of you. Katie, next slide, please. And I think we're all introduced, so next slide.
Okay.
Thank you so much. So as Katie mentioned, my name is Erica Kerber. I'm an attorney as well as the President and Executive Director of the Community Health Law Project. We are a nonprofit legal service organization that provides legal representation and advocacy to low-income individuals with disabilities, chronic health conditions, and the frail elderly. We have been in existence since 1976, so almost 50 years of doing this great and essential work. Our clients are comprised of individuals with chronic mental illness, intellectual and developmental disabilities, mobility impairments, sensory impairments that render persons blind or deaf, visually impaired as well, individuals living with HIV/AIDS, and more recently, persons with substance use disorders through some of our medical legal partnerships, as you'll hear, as well as chronic health conditions. We are a statewide legal service organization around the state of New Jersey. We cover all counties depending on the contracts that we have and the medical legal partnerships that we have in existence. We employ over 60 individuals. We have attorneys as well as advocates who also help clients. And we are skilled to assist this special population that we're talking about. And in almost the last 50 years, we've assisted over 90,000 individuals. We assist approximately 4,500 people per year in 5,000 individual cases. And we also provide lots of training, education, and outreach to the provider community, as well as to the consumers that we serve, to really try to educate them so they know to come to seek out our services if necessary. Next slide, please. And Sean, take it away.
Thank you. Good afternoon, everyone. I'm Sean Benoit. I'm the Director of Litigation here at the Community Health Law Project. As our Executive Director mentioned, our mission is to represent low-income individuals with disabilities, chronic health conditions, and the frail elderly. So to qualify for our services, an individual must fall into one of those three categories. We also do have a residency requirement. We do serve the entire state of New Jersey. Again, as our Executive Director mentioned, we have regional offices and satellite offices throughout the state. So we have a presence in all 21 counties here in New Jersey. With some of our grants being statewide, some county specific, the eligibility for our programs is going to depend on where the person resides. And then lastly, we do prioritize representing people who are low income. For our agency, low income means someone it has to be at or below 250% of the federal poverty line. So just as an example, now that we're in 2025, that means for a single individual, their yearly income would be $39,125 or lower to be eligible. For folks that are in attendance, if there's any agencies or any representatives here who are based in New Jersey, if you think you may have someone that would be eligible for our services and in need of our services, I would encourage you to visit our website for our office intake phone numbers and have them reach out. And all of our contact information and website information will be on one of the slides towards the end of the presentation. Next slide, please.
Thank you, Sean. So just to give you a little bit of a background in terms of our medical legal partnerships thus far, we're going to focus obviously on our great partnership with CarePlus New Jersey, but we have been doing this work probably since, well, I started doing research on medical legal partnership probably in 2016. Before that, we were just providing traditional legal services, as Bethany mentioned, in terms of the referrals that we were getting. And then in 2018, we were fortunate enough to attend a conference in DC hosted by the National Center for Medical Legal Partnership with my then predecessor at the time. And we learned so much from actually many of our colleagues around the country who are doing this wonderful work and really partnering and collaborating with the healthcare field. So once we started a partnership with an addiction agency in South Jersey to provide legal services to their individuals who were dealing with addiction issues. And STAR stands for Support Team for Addiction Recovery. Then we expanded to assist or to collaborate with providers working with the mental health population in specifically their PATH program, and that's geared toward individuals who are homeless or at risk of homelessness, as well as their intensive case management consumers. And then we expanded, as you'll hear today, with providers who offer CCBHC services. Obviously, Care Plus is one of them. We also have several others. And in addition to that, we do have medical legal partnerships with several HIV health clinics around New Jersey as well. So, you know, it's a great initiative. We really can provide that integrated holistic care that we're all striving to offer to all of the consumers that we serve. And you'll hear more about that as we move along. Next slide, please. And I think I'm going to turn it over to my colleague, Bridget.
It would help if I took it off mute, but thank you, Erica. So Katie gave you a brief introduction of who Care Plus is. So I'll try not to read everything on the slide, but we do serve approximately 14,000 unduplicated adults and children in the northern part of New Jersey. We employ approximately 600 people here at Care Plus. To put this in context, with the CCBHC initiative, New Jersey was one of 8 states selected nationwide in the initial CCBHC Medicaid demonstration program. The CCBHC model ensures access to coordinated comprehensive care, requiring clinics to assist anyone seeking help for mental health, substance use services, regardless of the ability to pay, their place of residence, or their age. And it's an integrated model that also incorporates primary care services. In 2017, Care Plus NJ became one of 7 designated CCBHCs in New Jersey, providing, again, that integrated holistic care through our existing programs and new programs. The federal demonstration is increasingly becoming the standard for the delivery of integrated care across the country. And just to put it in context, I believe as of today's date, there are probably approximately 500 CCBHC clinics and grantees, or what they call them, throughout about 46 states in the country. In 2023, Care Plus was awarded 2 additional grants under the CCBHC model. One grant is called the Planning, Development, and Implementation, what we call CCBHC PDI, to develop a new CCBHC service site. We targeted our Bloomfield office, which is Essex County, and the second to improve and advance the services that we are providing here at our Paramus site in Bergen County. Next slide. So CCBHCs and the social determinants of health, again, as the integrated model, we're required to provide 9 core services. So it's crisis services, it's outpatient, SUD, it's person and family-centered treatment planning, community-based healthcare to veterans, outpatient primary care and screening, targeted case management, screening, diagnosis and risk assessment, psychiatric rehabilitation, outpatient primary care, screening and monitoring. CCBHCs are responsible for ensuring all of the above services. If not available directly through the CCBHC, we can provide these services through what's called a designated collaborating organization, DCO. So this medical leadership, this medical legal partnership agreement services is part of a DCO so that we can provide services specifically targeting social determinants of health. Next slide. So according to the most recent National Council on Mental Wellbeing CCBHC Impact Report, CCBHC grantees reported that the model has helped them engage in targeted access expansions for people who have been historically underserved and to address social determinants of health in the community. So there's a no wrong door approach and philosophy for CCBHCs to remove barriers specifically linked to social determinants of health. We're responsible. We have to provide these levels of services, allowing individuals to generally heal, recover, and reduce their symptoms and lead more fulfilling lives. So CCBHC, this chart is showing you the the services and the strategies that are utilized to address health disparities, including increasing screening for unmet social needs. About 81% of the CCBHCs under this particular survey are saying that that's what they're seeing. Outreach to individuals who have historically been underserved or underrepresented, hiring staff who are demographically representative of the population that they serve. So CCBHCs are making particular focused efforts to support access among veterans, people experiencing homelessness, and those who are involved or at risk of involvement with the criminal justice system. The vast majority, 90% of CCBHCs are proactively assisting clients with finding or maintaining stable housing. Next slide. So I'm going to turn this over to Sandy to explain more about the specific partnership. Thanks, Sandy.
Yes, thank you. And as you heard Erica and Bridget talk about CHLP and Care Plus, let's talk a little bit more about the specifics of the medical legal partnership between us. So in 2019, July of 2019, we signed our first contract for the partnership, and we find that it enhances the quality of life of clients by addressing all the legal issues in a holistic and collaborative manner. Prior to the partnership, when we used to identify clients' legal needs, we would spend a lot of time, and I think Bethany mentioned a little bit about this before, spending time to try and find legal representation for our clients and their cases, if they were willing to take on their cases. We were frequently turned away due to overwhelming lists or sometimes the lawyers not even getting back to us on why they would not take the case. If they did take the case, often, again, Bethany mentioned the communication with the lawyers, it was very inconsistent. We at times didn't know what was happening, whether it be the case management or the client themselves didn't even know what was happening on their cases. So clearly there's the need there for the partnership. Currently now we have the clinicians and the case managers, they refer directly to CHLP for assistance with all legal matters. We often are identifying the early needs in treatment. So right from intake or early in enrollment, we are looking at what their needs are through assessments. And we use the legal screening tool that CHLP has provided us. And you'll hear a little bit more about that as well. That helps to identify what the needs are and know, let's refer them to CHLP before it becomes in crisis mode. Often the lawyers come to Care Plus or we go to them in the Bloomfield office. We working together with our case manager and the referring worker to resolve the issues and decide who's going to help the client with what part of the process to be able to assist on that legal case. So in turn, the attorneys then become integrated within the treatment team. It's very holistic and comprehensive, collaborative between them. Many of the clients are suffering from mental illness, addiction, co-occurring disorders, or other disabling conditions that impact their lives. By having that legal partner who's discussing those issues along with their support team, it helps them to keep it under, not in the crisis mode, as I mentioned, and therefore helping them to have positive results, to have less stress, and be able to concentrate on their treatment during that time. The legal advice that is given can be representation in certain administrative and court proceedings and drafting of certain legal documents. And by tackling them, they're avoiding the concerns of the legal cases and dealing with their essential needs impacting the legal concerns and therefore improving the overall quality of life. Next slide. Okay, so building our partnership. Over the years, we've developed, again, since 2019, the referrals were originally, and Erica mentioned this, STAR and Integrated Case Management Services, both our addictive recovery support teams is STAR, and both are basically outreach programs, often newly engaged clients in treatment. But over the years, what we have seen is that we now are seeing prescribers and outpatient therapists often who are working with the clients and identifying any legal needs that are causing noticeable obstacles within their treatment, therefore referring to CHLP early on to help not cause it to extend to further problems with their legal situation. Through that, we've also developed dual releases so that there's open communication between the clients and all the support staff, including the attorney. We find explaining this to the client and being involved and being okay with us collaborating along with their assistants helps them to understand they're part of that process. And we're all part of the treatment team, including that client. Having the designated person at CarePlus is really helpful, knowing that both the benefit system, the community resources that are available locally, as well as the overall operation at CarePlus, helps for us to understand and communicate between the lawyers and the social workers. We also began to track all cases using a shared comprehensive spreadsheet. So our spreadsheet is an ongoing live document. So if I'm speaking with Rohana and she's giving me a quick update, that information is getting updated on that spreadsheet. And at all times, we are sharing that with the lawyers. We share it with the case managers so that we all know on what part of the case we are at, what's our next steps. We also track opening and closing dates on there, attorney's assignment. Case management sometimes can change even midway through the case, as well as all ongoing case updates. Okay, next, thank you. Continuing of developing our coordination. So as I talked about the referral process and it spreading out through CarePlus, we found that it was helpful to assign and train specific staff members through the different divisions. As we've gotten bigger, our referrals have gotten bigger, it's helpful having a point of contact really to oversee each of those divisions, especially some that have more referrals than others. It helps with starting the referral and on the ongoing coordination for the updates. We've also developed our bi-monthly meetings. So that's usually between the CarePlus point person and the CHLP attorneys. We discuss all referrals and all open cases. We find that reviewing the cases really helps us to know the client and their needs, current needs, because again, that can change through therapy. We learn to speak the same language. We know that lawyers and social workers, we do have a different language, and we now need to speak the same language and understand both the legal system and the social work system and how that's affecting that client and their treatment. So by doing that, the clinical staff get to understand the legal process, the lawyers get to understand the social work process and how we come together to work with that client. The lawyers also get to know the agency, the different departments, sometimes the different departments and staffing patterns. How does that affect the care and the coordination that has to happen between the assigned staff person? We find that there are times that we discuss even the clients and how we can empower certain clients who want to be involved in their legal needs, whereas this in opposed to, we have some clients that need more support. Within those conversations, we get to discuss that and know what's the next steps. Who do we need to ask for that support? Often there's times that these clients are also multi-engaged, so they're in different programs. Sometimes we're incorporating other staff into the work that is being done with CHLP on the legal end. So having the treatment team meetings and coordinating not only different staff, therapists, case managers, sometimes supervisors, point of contacts, as I mentioned, all that really helps us to be able to see what's the staff's role, what's our next step, who needs to do what, so that we keep the legal process moving. Next slide. So through the process, we see clearly that we are building the staff's knowledge and expertise through this. Early on in the process, we hear about clients and staff come to me asking about the client's needs. Is this something CHLP can do? So we do have a lot of conversations even before referral to decide and determine when the staff should send that referral to CHLP. I think that's one of the steps really that I talk about with the staff and any referring worker. Is that client clinically ready to be able to work on their legal needs? If they're struggling with housing and the staff are working on certain social needs, that client may not be ready to resolve debt right at that moment. So that's just an example of how we might delay it for a short period to have that client ready to also continue working with treatment and their legal needs. Whereas another step that we could hold it off, I talk to the staff. Let's collect and organize. What are the legal concerns? What are the documentations that we need to provide and get ready for the lawyers? Because just referring, we need to have it ready. If we need to go to the courts first, we do. And if we need the assistance of the lawyers, we coordinate with them at that point. But having the documentation, sometimes clients have lost all of their legal documents, but still feel like, I need help. How do we help them through that process? Taking into account, we talk about deadlines. For example, if somebody is being denied their Social Security, we know that if they're denied, we only have 60 days to refer. So we need to do that quicker. We need to prioritize, put that extra support in there and make this happen. We don't want to miss those important appeal dates. We don't want to miss the court dates. They could be family dates, child support, court scheduled appointments. Obviously, we know with eviction, we know how quickly we now need to move and coordinate. So obviously through this process, the staff are increasing their we're helping them to increase their expertise. The lawyers, myself, any of the point of contacts, they help to learn and navigate the legal system that sometimes social works don't understand. So we've now also, through our partnership, last but not least, definitely the staff development and training. We've talked about doing trainings, and CHLP and Care Plus have coordinated. We've done trainings in the past about Social Security appeals, as well as the financial debt concerns. And we're looking at this year a little bit more in depth about Social Security and applications. And we're looking at credit concerns and how they can affect housing stability. So when we set up these trainings, we're able to, a staff person can ask the question, this is a concern for their staff, for their clients, giving them that training, giving them that background, it can help start the process to be able to know appropriate referrals to CHLP, what we can work on and what we need help with from CHLP. So I'm going to turn this over to Rahana, who's going to explain a little bit further about some of the barriers we saw.
Thank you, Sandy. As a result of the strong collaborative efforts that Sandy has just described, our MLP has been able to successfully address the needs of some of the most vulnerable individuals in our communities, most of whom face significant barriers accessing legal services prior to being part of our program. We all know that there are not enough attorneys to help low-income people. In fact, studies show that there is only one attorney per 6,415 individuals living in poverty. Also, individuals may not understand their legal rights or how the legal system works. And when people are engaged in mental health treatment, they often face stigmas about their circumstances. And this prevents them from asking for the help that they need. MLPs help to break down these barriers and these stigmas by providing a safe place for the patient to tell their medical provider about their legal problems. Healthcare and mental health care providers often have the trust of their patients, and they are already trained in screening skills, so they are in a good position to help their patients get the legal help that they need. In fact, we've found that when an MLP is involved, 81% of patients are open to discussing their legal problems with their doctors. And once a patient knows that their legal needs will be addressed, they do better clinically. Just the simple act of opening a referral for a legal issue has been shown to bring down hospitalization rates. Next slide, please. This is this beautiful picture on the right. It illustrates the social determinants of health, which we've been talking about throughout our presentation. And on the left, you'll see the descriptions of these, the wide range of legal issues that we handle. These descriptions actually came directly from our legal screening tool that Sandy mentioned. This is what Care Plus uses when reviewing legal issues and deciding whether a case should be referred to our office. So our MLP directly addresses these social determinants of health by helping clients with these legal issues. We address clients' economic stability by making sure they have access to public benefits such as cash and food stamps. We work to secure Social Security benefits for those who are permanently disabled. We address neighborhood and built environment by defending our clients from evictions, loss of important subsidies, and by making sure their housing is safe and habitable. We address healthcare access and quality by ensuring our clients have access to health insurance and fighting against denials of services such as personal care assistant hours or durable medical equipment. As to social and community context, we make sure our clients have legal documents in place so that important decisions can be made according to their wishes. And we also work on issues involving family relationships, such as child support and visitation matters. Finally, we address education and access quality by resolving school issues, such as making sure that students who have an IEP get special education and related services that they need. Next slide, please. Thank you. So I'm proud to say that since we began our MLP in July of 2019, our partnership has helped 124 clients to resolve over 162 legal matters. So why are there more legal matters than clients? Very commonly, people with low incomes have multiple legal issues that they are dealing with. So we often receive a referral from CarePlus for one legal issue. But once we speak to the client, we realize that there is another legal issue that needs to be addressed. Or sometimes a new legal issue arises while we are helping the client. So we are then able to help them in a holistic manner to resolve everything that's going on. Some of our MLP's achievements include preventing clients from becoming homeless. We've expunged criminal records, which were standing in the way of our clients' financial stability. We've helped clients discharge student loans when they were no longer able to work because they became permanently disabled. The consistent feedback that we receive from our CarePlus partners is that when we are involved, they are better able to serve their patients. When clients know that we are involved and we're helping with the legal issues, they feel less stressed about their situations. And this allows them to really get the treatment that they need and focus on that, including, and this leads to improved patient outcomes. Okay, we can move on, please. So we've had a lot of successes, and I just touched on some of them, but I really wanted to focus on a couple. So I chose these two because they really show how our close collaboration with CarePlus is key to resolving our clients' legal issues. So this first one is a 66-year-old woman with severe anxiety. So CarePlus referred the client after she received a notice from her landlord, and the notice stated that her unit was being sold and that our client would have to move in a very short period of time. So the client became extremely anxious about the situation. She did not know where she would go. She didn't have any family support. And definitely did not have any funds for moving. Her main form of income was Social Security benefits. And then the other issue was that she had a lot of debt, and this was due to her limited income. So we represented the client in landlord-tenant court, and we also filed an emergent Chapter 7 bankruptcy and made legal arguments in court that were able to extend the case proceedings for 9 months. And during this time, we worked hand in hand with CarePlus to locate and get her approved for a subsidized housing unit. And we also helped to find relocation funds for the client. So ultimately, the client moved into the apartment. And with her bankruptcy, she got a fresh financial start. And this allowed her to focus on her behavioral health treatment with CarePlus. So we can move on, please. This is the second story I wanted to share. This is a 59-year-old woman with depression who CarePlus referred to our office after she had been denied for the Social Security benefits that she really needed. So although she had been working for her entire life, she was no longer able to work after her husband passed away. And that had caused her to become severely depressed. And she, when she stopped working, she got behind on her HOA fees and taxes for her condo unit. And she was also at risk of losing her home in a foreclosure. So we worked on analyzing her medical records and getting her ready for her administrative law hearing. So the major challenge in helping her was that preparation for her to testify, because the client said that every time she talked about why she couldn't work, it brought her back, and she felt like she was reliving the tragic death of her life partner. So CarePlus provided her with the mental health treatment and support that she needed during this process. So with both of us working together to prepare her for her hearing, the client did a great job explaining to the judge how her mental health had been affected by her husband's passing and how that affected her ability to work. As a result, the client was found disabled by the judge, and she started to receive her monthly Social Security benefits. And she was then able to pay off her taxes and her HOA fees. With these challenges behind her, she was able to continue her treatment with CarePlus. And that's the end of the story.
Thank you. Rahana, I just wanted to kind of piggyback on that. Obviously, you heard from our great presenters here, my colleagues, and we've had a successful partnership for several years now, and it just keeps expanding. We keep on expanding on it every year because of the success, and to really try to help a lot more of CarePlus's patients. So thank you. Thanks for listening, and I think I'm going to turn it over to you, Katie and Bethany, for next steps. Any questions?
Sure. So we have a bit of time, and we do have some questions that came in. So I'm going to pose these and encourage anybody who has contributions to chime in here. One of them, I think, Sandy, I'm going to direct this to you. Somebody asked when you were speaking about the spreadsheet that you all use to share case information. So the logistics, how do you share the spreadsheet as a live document? And what, if any, encryption tools do you use to protect that spreadsheet?
We do have an encryption. I don't know what it's called. You're asking the wrong IT person. But we are able to send it encrypted to them. And we utilize it, as I was talking about, for our bi-monthly meeting. They're able to, we send it directly to Rahana and the attorneys, and they update it and send it back to us. And we use it the day of the meeting. So that way we're all ready and on the same page with questions and with updates. But I don't know the technical IT of what we're using, and I apologize.
Thank you. I'll pose this next question both to Sandy and to Rahana, I think. There's a question in the positive benefits section. What were some of the metrics used to measure health outcomes, and who helped with data reporting?
I did have a couple footnotes on there to cite to some articles that I found during my research. So a lot of it was actually from the website, and others were from some other studies that had been done by some hospital systems. I don't have them in front of me, but
Okay.
if needed, I can provide them.
No, that's a good reference. We can refer back to those citations on the slides, and we'll circulate those slides.
Can I just add to that too? So
Of
for this
course.
partnership, obviously you need financing to do a full evaluation of the outcomes, but we know internally, we know what the successes are, right? Working together. We did have a previous medical legal partnership about a few years ago through funding from a foundation. And part of that partnership, we included an evaluation piece and data collection. And we had an evaluation done, which definitely showed the benefits of providing medical legal partnership. We conducted surveys of the consumers and the patients that we served. And we also received data from the partner that we were working with that there was a reduction in hospitalization. So that our evaluation supported the work and the data that already exists from the articles that Rahana was mentioning. In order to do a full evaluation, you need funding to do that, right? That's an extra step, which we would love to do, but there are definitely resources out there that you can take a look at.
Erica, that was a wonderful segue. I was going to pose the sort of elephant in the room funding question and partner question to you and Bridget. We had a question submitted about generally, does this partnership include state agencies like the Department of Community Health, but also how do MLPs get through the ever increasing corporate red tape to get funding, in particular from hospital systems and clinics? So I'd love your thoughts collectively, individually on the funding and the partnership side of this.
I'm going to leave that to Bridget.
So I'll just say that there is no funding from state or county for this partnership. So when I said that under CCBHC, we're allowed to have designated collaborating organizations, that's how we're helping to fund this. So not necessarily through the state, but the funding does allow for us to have these types of partnerships. So through the billing that we do under CCBHC, we're allowed to have a contract of this kind of nature. But it's not funded under, county or state grant, if that's what the question is.
I'm not sure if it was that specific, but I think generally people are interested in how the funding for this works.
Just to add
as
to
well
that,
as the
so the other medical legal partnerships too, it's an investment by our healthcare partner. It's a subcontract, either through funds that they have, or what we also do is that when there is a grant or funding opportunity where we can apply together as a partner, or we can be a sub-recipient, we're written into the grant proposal. And if that's funded, we are part of that grant application and the funding involved. But it's either through an initial grant application where we're written into the application, or after the fact where, as Bridget said, there is an investment made by our partner after the fact where they're able to use some of the funding that they currently have to fund this initiative.
Awesome. Okay, we are at just a couple minutes left. If you have other questions, please put them in the chat box or in the question and answer. I know there are some that are maybe a little bit more involved that we may need to follow up on. But on that point, I want to keep this information on the screen for a moment so that you have the team's names and contact information and some other resources that they have shared here. Feel free to take a screenshot, or again, we will circulate these slides and the recording will be available. I want to thank everybody for joining us today. I know we have on another slide here, we do have a survey that we would love for you to complete so that we can get your feedback about this session. I just want to note that the work that everybody online and presenting here is doing today is really important work that has been incredibly challenging for a lot of reasons this week. So we really appreciate you joining us today, taking an hour plus to think through these issues, to be committed to these communities and to these patients and to this work. It's not lost on us that you have a lot of opportunities for how to schedule and structure your day. And We really appreciate you joining us here today. As I mentioned at the outset, next month, in about a month exactly, we will have part 2 of this series, exploring the Community Advocacy Program, which is a medical legal partnership between the Legal Aid Society of Cleveland and Metro Health. As I mentioned, this will be part 2 in this behavior and mental health series, and it'll be focused on pediatric patients. So that has the registration. Hope you'll join us for that. This screen has some other events that are upcoming. I'm not going to read it all to you, but there is a QR code. Feel free to scan that if you want to dig into the SDOH Academy and some other training opportunities. Like I said, you can also take a screenshot of this slide. Some other resources that we have on the National Center's webpage, a toolkit, planning and implementation guide, some briefs, and some other helpful resources that you can see here on the screen. And I think this is the survey link. We would really appreciate your feedback. It helps us to develop these webinars moving forward, to see what works, what doesn't work. Again, and thank you for joining us, for sending us your questions. We will do our best to follow up on as many of those that we couldn't get to today, but we appreciate the discussion. Thank you, team, for joining us. This was wonderful to highlight your experience in New Jersey.
Thank you. Thanks for having us.
Thank you.
Thank you.
Bye.